So if you remember, at our last meeting, we announced that AHRQ was going to be introducing a draft of common formats. Hold on, okay, hold on the agenda, that's great. That AHRQ was going to be launching a draft of a common format for safety event reporting, and we saw that as an opportunity to catalyze some work. And so we said we would come back on about 3 weeks after they launched that initiative. That initiative that release took a little longer than we had anticipated. It's right on time from their perspective, I'm sure. And so it's been a little longer than what we had envisioned when we talked to you last. But this meeting's really about now continuing that conversation and really taking some next steps. So, you know, other than my initial welcome and thank you for being part of the coalition, and thank you for being motivated to care about improving diagnostic quality and safety, which is such an important issue, of course. Today, we're really going to talk about the coalition strategy around this notion of diagnostic safety event reporting. Jerry Castro is going to take you through some of the technical details of what was in the release and what some of the preliminary comments are and what are some next steps. And then I'll come back and do a quick recap. And finally, Tina will end up the meeting with some next steps in talking about the next phase of the initiative. There'll be several places along the way for comments and questions. And so feel free to either put something in the chat box or just raise your hand or just say something if you need attention. When you're not talking, please keep your lines muted so we don't hear phones ringing and things like that. Next slide, please. So let me just remind us all of that which we already know. Diagnosis is a very complex topic, and this slide doesn't even do it justice in defining all of its complexities. It's something that always involves uncertainty. I always say that, except at autopsy, and there are errors at autopsy, but except for that, there is never 100% certainty around diagnosis. We know that diseases present differently in different patients. We know that diseases present differently within a single patient at different times. We know the whole notion of timeliness is very subjective, and there really no standards. And to the degree that timeliness can define a safety event, that makes it very challenging. And we know that there's no one right way for a clinician or a clinical team to approach a patient with a new complaint. And there are a lot of appropriate and permutations that involve judgment. And yet within this morass, we are challenged to try to improve quality and safety for all patients. And so that makes it a very challenging thing. Next slide, please. The current situation is even, or reflects this challenge. The local burden of diagnostic error at any one institution is really generally unknown, as the measurement systems operationally, especially in an operational sense, are quite immature. There really are, there's a shortage of tools. Dashboards and counting mechanisms are still very early stage, and even our incident reporting systems often lack a diagnostic category, and so diagnostic quality events or incidents can be spread over multiple categories or really invisible and therefore not really reflecting the true burden. When we try to learn from events now, we take a fragmented approach. Some things go to peer review, some things go to root cause analysis, some things don't even get handled in a structured format, and bringing all those separate learnings together into a coherent, integrated view, 360-degree view of the event rarely happens in most institutions. The very elements we need to completely and comprehensively describe a safety event, we don't have a standard. We don't really know what's really involved? Where do social determinants of health come in? Where do patient perspectives come in? So there's a lot that's just undefined. We lack feedback mechanisms for our clinical teams regarding diagnostic quality. And as I said, patient inputs are not generally integrated. Therefore, the ability to create sort of a national learning network or even regional or localized learning network is a struggle. We lack information and we lack standard approaches. Next slide, please. I don't know how many of you recognize this picture, but this is one depiction of the Tower of Babel. And if you remember your Bible stories, the Tower of Babel ran into trouble because of all the different languages, and it was hard for anyone to get to a finished product that reflected a coherent planning. We somewhat have this situation here now. We're in a very early stage of a field. There's lots of good work going on. I mean, over the last 5 to 10 years, CIDM certainly has seen an explosion of great work, but it's happening a lot in silos, and it's not necessarily additive or contributing to the evolution. It's very fragmented. And so the risk of that is that things take longer and potentially don't necessarily learn from each other. There's lots of reinvention. Next slide, please. So what we have described as the opportunity is we have a catalyzing event. AHRQ has proposed a safety event reporting system. And this creates an opportunity for the field to start down a process, a journey, to reach consensus on how do we document, investigate, and learn from such events. We have the opportunity to define what are the optimal data elements that should always be considered, not always collected, but always be considered in analyzing the safety event. We have the opportunity to define terms in a way that means the same thing to everyone. And we have the opportunity to define solutions that will be practical, because too often these reporting systems, et cetera, are cumbersome, administrative, not very flexible. So we have the ability to define something that's really going to be practical and scalable, and that we can allow to evolve over time. Next slide. So our current task, the one that we're really starting with right now, is to leverage this opportunity to just begin a process. This is not about fixing the common formats, but it's really about creating a consensus approach to event reporting, investigation, and shared learning. We need to ensure we are steeped in today's reality. We need to bounce our ideas against the realities of case studies that we're dealing with in our real life. We have to understand the burden of administrative systems that can impede our ability to use them. And we have to really design a future system with the future of diagnosis in mind. We know that diagnosis is best when it's not only a physician-centric, when it really is a team effort. We know that patients in a very fragmented system are the only common denominator, whether it be inpatient, outpatient, emergency room, primary care office, specialty care office, ambulatory centers. The patient is the only common denominator in any one episode of care. And so if we don't involve them, we will never really have a big picture. We know that there are new modalities such as telediagnosis. And as we've said before, we see telediagnosis as a subset of telehealth, but with very unique characteristics, because you are dealing with new complaints and you're not sure what information is going to be relevant and if it's easily obtainable through, if it's only a telephone call or a video call or whatever. And new tools. So we have to have something that's going to be robust and flexible. We want to design what we need, not just what we're limited to, what we can do. But we need to understand that we don't have to get to perfect right away. We want to get to perfect someday, but not necessarily right away. And so imagining an evolving approach that allows for flexibility, allows for us to find people where they are and not try to force organizations to be where they can't be will be very important. I think with that framing of where we're headed, big picture, I'm going to turn it over now to Jerry, who's going to take us through the discrete tasks that we have in front of us right now. So, Jerry? Oh, well, let me just stop, Jerry, and just say, are there any questions or comments? Tina, you wanted me at each stage that we pass the speakers, we wanted to just see if there were any comments or anything that people want to make at this point on, in this case, the big picture. Okay, none? Go ahead, Jerry, take it away. Thank you.
All right. Thanks for that framing, Paul, and I appreciate the opportunity to share our work right now. So I want to take a little bit of time to describe our work to date. And what we've been doing is talking through either just Zoom calls or email exchanges with coalition members to solicit feedback on the common formats. And you know, just granted that the timing of the release and the timing of these scheduled calls, some folks just didn't have an opportunity to really dig into the format. So maybe these were just kind of preliminary thoughts, or you know, just the first pass kind of thoughts, which is absolutely fine, because as I have these discussions with more and more peoples and more stakeholders, it tends to refine my thinking about the common formats and some of the nuances involved in at a high level, but also at a relatively granular level, the data element level. We've also talked to we've engaged with patient groups that are not part of the coalition to not only educate them about the common formats, but also to solicit their feedback about, from a patient perspective, what are the things that that we should be paying attention to, quite frankly, when we want to collect data and then ultimately learn about these types of events. So for today's work, I'd like to walk through the common formats, not only at a conceptual level, but also, I will go over the form. And so if you have not had an opportunity to look through the form yet, or parse out some of the data elements, I'll go through reasonably quickly, not necessarily stopping to dissect every single data element, mind you, but just to at least expose you or, get some thoughts going. I would highly encourage you to use the chat if you have any questions, or if you have any background information, any perspective that you would like to share, because we will be saving the chat. And of course, we will be utilizing this discussion today, the chat, the ongoing conversations to continue to evolve our thinking around the common formats and diagnostic safety event reporting as a whole. And then finally, of course, my last bullet here, how to submit comments. So we do have this task of submitting comments to the through the National Quality Forum process, which I will, at a very high level, describe. So again, the AHRQ common formats are standardized definitions and categorizations to collect data on patient safety events, right? It is not a reporting system. Again, not a reporting system. It is intended to be used by healthcare providers and organizations to work with PSOs for patient safety event reporting. But it is available in the public domain, so this framework and these classifications are available to anybody who wants to use them. And then, of course, there are event-specific modules for hospitals and nursing homes, and there's the link there if you want to see more of that overview. And so when AHRQ releases a new common format, for public comment, they utilize the NQF process, and so this is I would say somewhat different from the traditional performance measure review, in that it is just out there. They engage with NQF to coordinate the process of obtaining public comments, and then they go through an expert panel process, which is described here. So. The AHRQ common formats were released on they were released on June 1st, and the commenting process will close on July 1st. And so NQF will collect and coordinate those comments and submit those comments to an NQF expert panel, where we will, I'm a member of that expert panel, as along with several other participants in today's call. And we will review those comments and then develop recommendations, which will occur. The expert panel will review the comments in early August. We'll develop recommendations in late August and early September. We'll submit those comments to AHRQ, who will consider the recommendations, and then they will issue the comment formats themselves. So going through the actual formats themselves for diagnostic safety, there are three different documents if you have not seen them already. There's the guide, the event descriptions, and the form. And of course, you know, not all of us read directions, so I would highly recommend that you start with the guide. And it does actually say that in the guide, start here, because the guide helps to set some of the concepts and definitions, how those concepts and definitions are organized conceptually as well. And then it lays out some of the other, I'd say, you know, one of the details around diagnostic safety event reporting, which I'll kind of explain in the coming slides. So one of the things that it says explicitly in the guide itself, that it is not that the comment formats are not intended for frontline reporting. Okay, and so I think that's an important point. So you identify diagnostic safety events through other mechanisms, and then utilize the common formats as an analytical framework for looking at diagnostic safety events. So the different sources of these types of events can be through patients themselves, either through communications with clinicians, event reporting, complaints, claims data, and then even, you know, or even through open notes, you know, commenting on clinical notes. So those are mechanisms, existing mechanisms and new mechanisms for hearing and communicating from patients, communicating with patients and hearing about potential diagnostic safety events. There are traditional quality and patient safety improvement activities, which also include, which not only include, you know, peer review perhaps, or I'm sorry, peer review is in a separate category, but quality and patient safety improvement activities will include the use of global trigger tools perhaps, or looking at medical records, and then risk management and then peer review processes, and then finally traditional incident reporting systems. These can be potential sources for identification of diagnostic safety events, and this is actually explained in the guide. So here's the definition for diagnostic safety events. So when I look at this definition, I see that there are different elements here to point out. You know, pulled from the National Academy of Medicine, from Hardeep Singh's definition and concept of missed opportunities. So, you know, so they define diagnostic safety event as one or both of the following occurred, whether or not the patient was harmed. Okay, so that's an important concept, whether or not the patient was harmed. So it can be a harm event or a close call or a hazardous situation, but there are two components to this definition. So there's the delayed, wrong, or misdiagnosis, and the diagnosis that was not communicated to the patient. So within the delayed, wrong, or missed diagnosis, we have components of the National Academy of Medicine definition where there was a missed opportunity to pursue or identify an accurate and timely diagnosis, right? So those are two components from the definition there of the patient's health problem based on information that existed at the time. And so I think that's an important concept. Based on information that existed at the time, right? So keep that in mind as we continue to go through the rest of the format. Diagnosis not communicated to the patient. So this is an important concept, again, from the National Academy of Medicine definition. So the accurate diagnosis or other explanation of the patient's health was available, but it was not communicated to the patient, which includes patients representatives or family. So again, another concept to remember that wherever you see patient, that it also includes patient, representative, and family members, okay? So I actually fell into that trap as I was going through the form itself, and I highlighted, well, it also applies to the family. So keep that in mind as we go through the form, that patient also applies to patient and family members, okay? So again, as I was going through the common format itself, I was thinking about framing, right? And ultimately what we want to do today, or what part of the activity of today, is to develop a shared mental model. And I know, at the Joint Commission, we use that term a lot, but it's important, because I think framing the conversation and trying to, create analogs to what we've seen before. When I was reviewing the common format, I kept thinking about this model, right? This is our traditional approach to contributing factor analysis, right? We want to figure out the who, what, why, where, and when, right? So again, if you're new to this, to patient safety, or even patient safety event reporting, keep these in mind as we dig into the actual formats themselves. These are the things that we're trying to characterize. And as I was going through each of the components of the format, I kept thinking about this component of the contributing factor analysis. And so just to walk you through what you're looking at here, in a contributing factor analysis, or traditionally what is traditionally called a root cause analysis, we see that a patient was harmed. This was the final consequence, right? Patient harm. And then we have to figure out what led up to that patient harm. So what we do is we develop a process flow diagram where we figure out what were the specific steps that led to that harm. We determine what were the initial factors that actually precipitated the sequence of events. And then ultimately, we want to figure out the why. Right? Why did this happen? Why did this particular components of the event happen? We call these contributing factors. Once we identify and characterize these contributing factors, we can develop actions to reduce those things from happening, or prevent those things from happening. So that's why this whole diagnostic safety event activity reporting is so important, because we want to be able to identify and characterize those things that we need to fix. All right, so identifying the why factors. And so as we dig into the actual common format itself, I found myself orienting the concepts contained within the formats in this way, right? And so this is Jerry Castro's depiction of the common formats. This in no way represents, AHRQ's conceptualization, but it was helpful in my thinking of it. So in the common format, they describe the event trajectory, which starts with the first diagnostic episode, where the patient begins their healthcare journey, right? And the event trajectory concludes with a final diagnosis, where the accurate diagnosis is established, right? So these darker blue shaded boxes are where we collect information. These are the sections of the common format. So we want to collect information on the diagnostic episode with missed opportunities. And I should also say that, within the event trajectory, there are multiple diagnostic episodes. We go to our family practitioner and they refer us to a specialist. So when we go to the family practitioner, that's our first diagnostic episode. When we go to the specialist, that's our second diagnostic episode. And, the common format describes, how you, and I'll go through those definitions in a moment, how you can characterize diagnostic episodes. But I will say that within this event trajectory, the diagnostic episode with missed opportunities can occur at different stages. So this is just one event, all right? This is not representative of all events. This is, how one event could have transpired. That being said, all of the dark shaded boxes represent a component of the common format today. So we want to know about the diagnostic episode with missed opportunities, and we want to figure out, well, what was the certainty of that diagnosis? What was the setting? Where was that, diagnosis performed? What was the documented diagnosis at that time? What information could have led to an accurate diagnosis? And then the type of diagnostic process that describes the diagnostic episode, and then what were the contributing factors, right? So again, if you think about my previous slide, the diagram, the contributing factors, right? These are the things that we want to characterize with these missed opportunities so that we can figure out what to fix, right, in patient safety. The other component is the final diagnostic episode. When was it identified? What was the accurate final diagnosis? Was it in fact communicated to the patient, right? Another criteria for a diagnostic safety event. The setting that this occurred, and then what ultimately led to the discovery or recognition of that final diagnosis. The other components of the common format are characterizing the impact on the patient, which is important. And I think our patient and family facing groups will have a lot to say about that and helping us better characterize those impacts. And then finally, patient and reporter data, and then the brief narrative, which is optional. So actually, let me stop there. I know I threw, this is at a high level, the organization of the information and, and how it struck me. My next step is to dig into some of the concepts and definitions, and then ultimately walk through the form itself. All right.
Hi, this is Lisa Miller. I don't know if it's a question or just a comment. I guess with final diagnostic episode with what led to the discovery, that almost feels like separate to me. I don't know what other people's thoughts are.
Yeah, as far as, you know what, let me hang on to that question. When I get to that section of the form, you'll see how that's actually, how that actually breaks down.
Okay, so, yeah, that might be helpful.
Yeah, absolutely.
Thanks.
Okay, great. So let me move on here. So let's go into some of the concepts and definitions. And let's start with the event trajectory. As I mentioned before, it begins with the first time the patient presents to in any healthcare setting or location, and then it ends when the accurate final diagnosis was pursued or identified, right? So that is the entirety of the event trajectory. Each diagnostic episode is defined as a distinct point in time or period of time during the event trajectory. And as you can see, there were multiple diagnostic episodes, and some were diagnostic episodes with missed opportunities, right? And so this is a diagnostic episode with missed opportunities is defined here, and based on information that existed at the time of the diagnostic episode, right? Something different could have been done to pursue or communicate the accurate final diagnosis earlier, right? So and these are just verbatim, the definitions taken from the guide, but it's important to help frame the discussion here. So the actual form itself, as I mentioned in my diagram, is composed of 5 different sections. And it starts with the accurate final diagnosis, details about one diagnostic episode with missed opportunities, and the third section is the impact on of the diagnostic safety event on the patient. The fourth section is patient and reporter data, and then the fifth section is optional, which is the brief narrative. I will say that there is guidance that you don't have to you don't have to fill out information on every single diagnostic episode with missed opportunities, but the guidance actually recommends doing this kind of analysis perhaps on the highest impact diagnostic episode, or perhaps the most frequent. So let me dig into the form itself. Okay, so hang on tight. Okay, so this is what the diagnostic safety event reporting form looks like. Okay, so we start at the top. These are the different sections that I explained. And what's nice about this form that that AHRQ has created is that you can click on the form itself to go to different sections, and it'll immediately jump to the section. So as I mentioned, it's the accurate final diagnosis, details about one diagnostic episode with missed opportunities, the impact on the patient and reporter data, and then the brief narratives. And so again, as we go through the sections of the form, we're gonna go into pretty granular stuff, right? But I want you to keep in mind at a high level, what we're trying to do. We're gonna try and characterize the contributing factors. We want to characterize what type of event or I'm sorry, what type of process we're talking about within the diagnostic episode. And then of course the impact and patient reported data. Okay, so let's dive into the accurate diagnosis component. So, the first question is about the actual ICD-10 code and about the accurate final diagnosis. And then if no medical or psychiatric diagnosis, other accurate explanation or health problems. So there's this, there's always going to be, as we, go in event reporting, we always like to have an other or an opportunity for folks to fill out more narrative. And so that helps to characterize the event. And then of course, there's the balance between categorical data and then of course, narrative data. So there's that. Item 2 is the specifying the actual date of the accurate diagnosis. And so this becomes important in a minute, which I'll show you. And then once the accurate final diagnosis was identified, was it in fact communicated to the patient, right? And so what's interesting to me is that, on this section already, we were already talking about accuracy, timeliness, and whether or not it was communicated to the patient. I mean, this is like the top end, whether, so to me, these kind of help establish whether or not these were in fact an event. So let's move on to the next section. Here's information on the setting, and you can select which kind of setting. And I will say that virtual care is at the top here, which is interesting to me. I think, if I recall correctly, it's not currently part of the Common Formats core. So I think that would be a really great addition to that. And then the time to accurate final diagnosis. So you remember on the first page, we captured the actual date that the accurate final diagnosis occurred. And then now we're looking at the difference in time between the accurate final diagnosis and then the first diagnostic episode. So you'll see here the unable to calculate. Okay, fair enough. And then also you can quantify it in terms of minutes up to years, right? And so some folks might be saying, well, why would minutes be relevant, right? I can think of, perhaps, failure to rescue, or, failure to call a rapid response team, right? Or, identifying a deteriorating patient. Or in the case of years, it might be a diagnosis that was, it was one of those rare diagnoses where it took many years, many, professionals to try and figure that out, many specialties. So that's why I see the difference between minutes and years. So I think that's interesting to capture. Here is information. In this particular question, they ask about the number of diagnostic episodes within the event trajectory. So if you think about my diagram, it's just counting the number of, well, quite frankly, it's boxes in my diagram. So that's captured there. And then in general terms, what prompted the discovery of the accurate final diagnosis? Okay, so what happened, right? What was the thing that led to the accurate final diagnosis? And you can read the different options here, but And one of the things here that I like to see is, it was patient initiated, right? So for the patient and family facing groups, this is the, where, I have been telling you about my condition. I've been pursuing this diagnosis, or, and you see this kind of description here. And so describing that is where this component is captured. There are other components here, such as the symptoms did not resolve, or the patient's conditions deteriorated, fresh eyes, so on and so forth. Discovered from transition it to a different location is this item right here. And then, discovered as a result of follow-up. And then finally, there are other ways that we find these things out, through complaints, lawsuits, and unfortunately through patient death. So that is the accurate and final diagnosis question. And I'm sorry, I haven't been following the chat. So if there are any, questions in the chat that need to be resolved, let's see. Okay. Nope. Okay, I'm not seeing any. Okay. So let's go into section 2. These are the details about one diagnostic episode with missed opportunities. All right. So again, that's that dark shaded box in my diagram. And so what we want to characterize are different elements of this particular diagnostic episode, where we could, seek improvements, right? So that's the point of identifying.
Jerry,
this.
sorry, this is Dave Newman-Toker. Sorry, before you go to the next section, I couldn't tell when you were going past it. Is there a place to record what the incorrect diagnosis was rendered?
Yes, that's correct. There is. And here you go. That's actually section 2.3, the inaccurate diagnosis, and then if there was a differential or rule out list as well.
Okay, great. Thanks.
You're welcome. Any other questions, thoughts, before we dive into diagnostic episodes with missed opportunities? Okay.
This is Helen.
Go ahead.
I had asked in the chat, and we can get to it later if you want, but I really like the question about the communication with patient and family. I just curious where, if anywhere, that could be found in a record. That seems like a pretty high, pretty difficult thing to capture.
Yes, that is a very good question. And, just outside of this work, we're still trying to crack that nut, quite frankly. Whether, I'm most familiar with MedStar's program for, We Want to Know, right? That was their program, and they encouraging patient reporting and communication. And so trying to figure out those mechanisms around getting a better, that flow of information are definitely an issue, I think, that would be supportive of this effort as a whole.
But Jerry, let me just build quickly on Helen's comment. I think, especially with the recent rules about clinical notes being immediately and freely available to patients, and let's set aside how low the read rate might be for a second, but that may be the mechanism of communication, and whether or not further documentation of the patient having read it or not, I mean, that we'll still have to confront. It's an unresolved issue, but that may be the mechanism for documenting that we should consider.
Yeah, I actually got a question from the patient and family group that we convened. Can patient and family members fill out this form and submit it to their providers? And, I said, sure, why not? Can they use this potentially as a way to facilitate that conversation? Just looking at those, I think the challenge for organizations is really formalizing this mechanism, right? And I think that's another area that we want to see more work done.
Jerry, I apologize. Just before you go on, one more question. Is there a place to record what the presenting symptoms were for the patient?
Presenting symptoms. I believe there is not. I don't think it goes into that detail. Oh, wait. So, and actually, if we could, if I could pick on Gordy Schiff, because some elements of these, the common formats are actually based on the deer taxonomy, right? And so at a high level, you'll see, Gordy, I have on my screen, the chief complaint, the order history, previous documentation, and it's very similar to the organization of the deer taxonomy, right? So would you, would you see capturing that type of information here?
Well, you are showing us something from the format that they've created that does.
That's correct.
Capture that. I guess to give a little personal bias here as part of the committee, I thought sort of an orienting brief narrative would be, a summary would be in a narrative form was a good way to capture that the person first presented with, blood in their urine, etc. But so that's, I guess, at the end, and it's optional, but obviously this does capture chief complaint. I guess the thing that Paul just said is really kind of important and intriguing, thinking about what Helen the person raising this. We can document everything in the record, and now the patient has access to it. So I can wash my hands of communicating with the patient. I put it in writing, and they have it, and that's the end of it. That might be one posture, which we think I would say is sort of antithetical to real meaningful communication. So this is a very murky and brave new world. I think we should recognize. And even this whole idea about communicating with the patient is a very static, one-way notion that you're going to come up with a diagnosis and tell the patient. I think that there's something even flawed with the IOM definition there. It's very kind of not catching the rich dynamic interplay of communication over time, interactive. So anyway, we're left with that is the current state of the art, but I don't think we should feel comfortable with that totally either.
Yeah, I definitely think that is the next area to pursue as far as that mechanism. But jumping back to the form itself, I did want to highlight at the top here with diagnostic episodes with missed opportunities, capturing the certainty of the diagnosis at that time. I know that there's a body of work in this field where we're trying to capture diagnostic certainty. So this is a nice addition as far as I can see. We talk about the settings of the diagnostic episode with missed opportunities. I mentioned the capture of inaccurate diagnosis in the differential list here. And then going into elements of follow-up and further feedback. So these are components of closing the loop with the patient, right? Was there a follow-up plan, and was that in fact finished? This component we talked about just a moment ago, what was the key piece of information, where we can capture that could have led to the accurate final diagnosis, but it was missed, right? So this was the missed opportunity. And you can see that it could be complaint, perhaps the symptoms go in there, other history information, and so on and so forth. And you can see the different types of information that can be entered there.
I think it's an important omission, this issue of systematically recording kind of the nature of the clinical presentation. Because if you think about this for just a second, when you go to implement solutions related to improving diagnosis, patients don't show up with a disease, right? They show up with a symptom or a problem. And I do think that it's a critical issue to be able to consistently codify every one of these diagnostic errors as falling into a particular, sort of bucket, even if it's, multiple complaints, even if, there's a bucket for many different complaints. But I think in general, the idea that you have some kind of way of grouping them so that you can start to look at, okay, which clinical presentations are we missing on a regular basis, and then implement solutions. I think that's an important problem if that's not a routine part of the reporting.
Yeah, and I think I could see that from this component of the form, although it's not as categorically oriented as this component, which talks about the specific diagnostic process. And again, this is at a high level based on the deer classification. And then, with regards to the specific elements of the diagnostic process, whether it be patient access and communication, or history, and then physical exam and lab tests, we would seek to characterize what other additional details would be known about the specific process. And I will say that the list of additional details are very similar for each of the types of diagnostic processes described in A, B, and C, and so on. But there are different elements such as with patient access and communication, there could be a delay in care due to transportation issues. Speaking of, the patient's ability to access healthcare, right? And, we talk about insurance. And then I would also, I think that we would like to add some components about not being able to, communicate to the appropriate clinician here too as well. So let me just quickly go over these sections here. So there's the physical exam. Other differences here would be with the lab tests here. So you have the ordering clinician and then the interpreting clinician for lab tests, which would be one difference there. And then also with imaging and other diagnostic testing, ordering and then interpreting clinician. In addition to the other environmental factors, patient factors, and so on. And then consultations and referrals, same thing here. So very similar for the different diagnostic processes about the additional details. So when we identify these additional details, these are process things that we can potentially fix, right? And so from a patient safety perspective, these are the contributing factors that we want to help identify and categorize, that we can ultimately develop actions to reduce risk, or develop action plans. And then follow-up tracking. And then interestingly here, this one characterizes the overall diagnostic assessment. And this reminds me of the National Academy of Medicine diagram that describes the diagnostic process. Selecting, gathering the information, integration of that information, and interpretation, and then so on and so forth. So those are the different processes described there. And then here's where we get into the contributing factors of the missed opportunities. What actually led to that diagnostic process problem, right? So we go through different issues that we talk about a lot in patient safety: communication issues, safety climate and culture. Within the team itself, was there an issue? We talk about resources availability, workload and staffing. I think this one's interesting too, because it also breaks it down into consideration of clinician qualifications and proficiency, right? So that's an interesting issue which sometimes we tend to stay away from in patient safety. We talk also about supervision support, policies, procedures, and then handover and handoff and care transitions, and of course the crisis situations, which are always just, that throws everybody for a curve. So that is the section on missed opportunities there. Okay, so
hey,
hang on. Oh, go ahead. Yes.
This is Steve Levy from Washington Patient Coalition. I just sent a comment out. I was wondering why under that contributing factor area under communication, it doesn't include something about between patient and clinician or something like that. I mean, that they actually, mention that as one of the misdiagnosis, definitions.
That's a good point. That's a good point. Thank you for that. We captured that, and we will we'll include that in our submission of comments. Thanks, Steve. Any other thoughts or comments there? All right, let's jump into the impact to the patient. So again, thinking about the diagram, we have this event trajectory which led to the final accurate diagnosis, and then what happened to the patient. So I will say that with impact and harm scales, and the folks that have been in the discussion of classifications and patient safety event classifications, there's this whole discussion about harm scales, which I'm not even going to get into. But I will say that this is consistent with the existing common format harm scale, right? So there's none to mild, to moderate, to severe, to death. Okay, so that is the harm scale, right? You can read the definition of the different categorizations here, but I will say that there's this added probable impact severity unquantifiable, which I really think is interesting. So the condition probably worsened to a clinically meaningful extent due to circumstances related to the diagnostic safety event, but it can't be quantified. We don't know how to quantify it, right? So I think that's an important addition. Also, another component of the harm scale is whether or not it was permanent or temporary. So that question is here as well. And then I think this is another great addition here. In what other ways did the diagnostic safety event and not the underlying disease affect the patient and family, right? So we talk about emotional harm, we talk about financial impact on work, school, life, and then other impacts that are that need to be further delineated. So I think those are very good additions there. But then there are other impacts which I'll get into in a moment, from the feedback from our groups. So that there's some really great additions. Finally, the final section here is the patient and reporter data. So this is the age, the gender, the ethnicity, race, and then who participated in contributing information, right? So you'll see clinicians, supervisors, clinicians, patient safety, improvement professionals, and risk manager, and then of course other. And then finally, the optional brief narrative. Okay, so that's the end of the form. Whew, deep breath. Congratulations, you've made it this far, and thanks everybody for your kind attention. But let me go through what our coalition members found, right? So at a high level, it was, we received feedback that it's important to emphasize that this is diagnostic safety event reporting. This is not reporting for, finding errors. This is safety event reporting for shared learning and ultimately not for measurement. It's shared learning for improvement. We've received some feedback that as they stand today, the common formats are somewhat physician-centric, and other contributors to the diagnostic process are not well specified, such as nursing or techs, so on and so forth. We hold that diagnosis is a team sport, and so those kinds of contributions to diagnosis need to be better characterized. The patient is not listed as a contributor to the analysis, and so that was actually a specific point here. Who participated or contributed information? Well, the patient took the journey. And sometimes they do participate in the analysis as well, right? So I think that should probably be an option. The other point here that was brought up, the trajectory of events ends with a final diagnosis. And one of our patient and family group members, brought up, well, what if we don't know we don't have a final diagnosis? And what if we don't know it's an accurate diagnosis? What do we do then? And so, some more thought needs to be given to that. And then also for hereditary conditions, that needs to be communicated to patients and families, right? Otherwise, there is an impact if it's not communicated in a timely way. So very, very important point. The disparity in equity data for patients and providers, that's an important issue that we're still trying to figure out with regards to diagnostic disparities. So better data on those types of issues we would benefit from better data on that specific element. And then there were specific comments on the different data elements themselves, which we will also collect here. And then of course in the chat there's been great conversation about specific elements. So deep breath. Let me stop. Are there any questions about any of the material that I went over?
Can I ask one basic question? Maybe it's obvious. We're putting in dates. We're putting in HIPAA protected data elements here. But this is supposed to be widely shared, or explain that. You know, we want to know what date did this event start. So what's the thinking on that? And
that's a good question, Gordy. And I think if it is shared in the context of a PSO, as a patient safety work product, as you know, the common formats are intended, you know, it is protected. And especially with so with this type of event analysis, and I can't remember who I was having a discussion with, we were trying to figure out, well, you know, at what level would this analysis best take place? You know, is this at a patient safety department within an organization? You know, can they pull that information from multiple patient visits, even outside of their healthcare system? Would this be more appropriate for a PSO, perhaps? Or maybe even, you know, a larger health system where, you know, and I'm thinking of, you know, perhaps like a Kaiser or something like that, where it's somewhat of a closed health system, and, you know, the patient goes within that care for that health system. So, you know, we were trying to figure that out, and we didn't quite come to an answer yet, but that's the immediate use, or, you know, answer to your question. It is intended to be within the context of reporting to a PSO.
But I think that brings up another question. To the degree that our goal is to create a standard approach to analyzing, investigating, and sharing learnings from safety events, how do we extend this with in non-PSO environments? And that's something we will need to think about.
Any other questions before I hand it off to Paul?
Jerry, this is Becky. I do have just one other comment. To ensure that all events that really should be considered for this type of analysis are considered, one concern I have is that if people are taking the definitions literally, when you look at the definition of event trajectory, and even a few of the others, event trajectory in particular says it's for the purposes of diagnosing the health problem. But with something like an incidental finding, that initial presentation isn't to diagnose that health problem. So my concern is that if someone falls and they go to the ER and they have a chest x-ray because they think maybe they broke a rib, and there's an incidental finding on the x-ray, that wasn't the health problem that they initially presented for. And the way it's worded, if someone takes it literally, really wouldn't include those types of events. So I didn't know if that had come up in the discussions at all.
No, actually it did not. And thank you for bringing that up. I think that's, you know, so one of the things that I would love to hear about are organizations that, you know, quite frankly, they kick the tires, right? They give this a test. They run cases through the common formats, you know, and see, well, what are the things that would be beneficial to find out? And I see that Rachel has raised her hand. Go ahead, Rachel.
Trying to unmute myself. So I did actually get an opportunity to go through 5 cases on this. In my role, I'm a director of patient safety for a chunk of Advocate Aurora Health that includes 3 hospitals. So I had a lot of options to choose from. And I just wanted to comment that this is not doable from a chart or record review. The level of information that's asked for definitely requires an actual event analysis. So I think you can put some elements in based on a chart review, but you absolutely need to have those conversations with whoever's talking to the patient and family and the clinicians who are involved. And I will say one of my feedback was actually about you know, there are a lot of events that we investigate in my team that have elements that are physician-based, but also elements that are other members of the diagnostic team. I think most commonly nursing, but certainly physical therapy and team members of that of those roles. So that's something I would like to see a little bit more robustly. And then as we were talking through it just now, one of the things I wonder about in terms of documentation is when we do have an idea of what the cognitive bias was, if there was one, is there a way to capture that? But so that's where those were my comments in terms of having had the opportunity to test this in I think a slightly different form.
Excellent. Thank you, Rachel. Any other comments or feedback? All right, hearing none, let me pass it off. Oh, I'm sorry, go ahead, Gordy.
I think one of the things that, obviously the last comment talks about how much detail is required here and it's considerable, and is that going to inhibit that? So that's, I think, an ongoing discussion. The other has to do with the centering this around encounters, discrete encounters where there was an opportunity for improvement. And I think, in working on this previously, there was a lot of discussion about that and how to keep it that way or move away from that. And I think that's sort of a fundamental feature here that in some ways simplifies it, because you want to just touch down on that ER visit or that initial primary care visit. And there's some good explanations of how that would happen with the spinal epidural abscess case. But on the other hand, I think many of us know that the way these illnesses evolve, it's not, so much specific points in time. It's a continuum of things happening with symptoms evolving and different information coming. So the real world is not quite so discreetly bundled, I would say. And I think we need to come to terms with that, at least recognize what's been done here to focus it in this way, and if that was the best choice.
Yeah, I take your point, Gordy, and that was actually brought up by one of the patient and family groups. What if I have a complex diagnosis? How does this actually work? And again, it's like I didn't even think about that. What if there are multiple diagnoses and the complexity of that, and trying to figure out, well, how will this actually work is one of the things that I want to test out. And I see that Steve Levy has his hand up.
Right, thanks, Jerry. Is this primarily focused on acute care? I noticed some of the responses do include, rehab, et cetera, but it seems very acute care focused. Is that kind of?
Yes, yes, that is correct. This is for hospital event reporting.
Okay.
Good question. And then I see Hardeep has raised his hand.
Sure. I'm going to just quickly reflect on the acute care comment. I think you can put in any comment on this. It doesn't have to be acute care. There's outpatient events. There's all kinds of events. And anybody can use this, not just, for hospital reporting, because it's a useful tool overall. So we had the privilege of working with AHRQ and trying to, test this out in 8 different organizations. And one thing we found, which was consistent, was this is quite burdensome to fill out. And you should have seen the earlier versions of this instrument. So I really appreciate the spirit of let's add this and let's add more fields to this to make it more comprehensive. But you got to realize that people are not going to be able to sort of do this easily. So we have to really balance how much more information we want to put on this. So that's my only sort of word of caution as people think about submitting comments to make it more comprehensive. Thanks.
Hardeep, it's Steve again. Thanks very much. You with that perspective. I was just curious because I know things have changed a lot in our society, and home health care has become a little bit more prevalent, but I didn't see any responses or anything really focusing on, while in the home I found this and now I understand why this happened. Things like that. So it's not very home focused. And I know we have other in there, but I just didn't know if maybe the home side of thing might be more relevant in terms of diagnostic, medicine these days.
I mean, absolutely. I don't think this is exclusionary for any of the settings of care, including the home. I think that's where the other category is fairly useful. I would just think that even if you can get just the outpatient emergency and hospital settings to give us data on this, that would be a great start. We're so far away from, getting all this data from the home environment. We're not even getting this from the hospitals. We're not even getting this from emergency rooms or outpatient settings. So we're so far away from some of the things that, we want to get to. So I think it'll take time, but this is a conversation starter. I think that's all this is. This is just a conversation starter. Get it out there, get people to use it, get some data, get people to think about all these categories, and then go from there. I mean, this is just a version. I don't know what they call it, but I'm assuming there'll be further versions around this.
Good point. Thanks.
Yeah, agree.
This is Dave Newman-Toker. Just to reiterate this issue of the initial clinical presentation, I think there's a lot of stuff you could take out there about process and causes. There's an enormously detailed section there, but I think people are going to struggle to figure out how to actually implement solutions for patients if they don't know when they're missing them, under what clinical circumstances. I think that's a critically important thing. And if the form is burdensome, I would take that out somewhere else and add that up front.
That.
Okay, Jerry, we ready to move on? Next
slide.
Next slide, please. So this will be just a quick recap and then moving into some next steps. So, Jerry just did a great job of taking this deep into the details. And, but we also want to keep our eyes on what the long-term goal is. It's not about fixing the common format. It's about reaching a consensus approach to event reporting, investigation, and shared learning. And so we will certainly keep our eyes on that sort of true north. In the intermediate term, we think the role for CIDM and the role for the coalition is to work forward towards envisioning what is the ideal system and developing a roadmap to get there. And as has been pointed out, this is burdensome, administratively heavy. It cannot just come from a chart review. We've heard lots of great comments. And I would say that, initially, I think the ideal, we need to not censor ourselves, not worry too much about feasibility, but really imagine what would be the ideal and then work on how do we make it feasible, as opposed to starting with feasibility and never hitting the ideal needs. So it's got to be practical, it's got to be scalable, it's got to be flexible. And, to Hardeep's point, people will start taking shortcuts. They will skip fields. They will skip to the next step, et cetera. That's already going to happen. I think it's still important to imagine what is all the right information. What I worry about, as we've learned with the electronic health record, is that people get into a rut of, I'm always going to skip questions 3, 9, and 15. I'm just going to do my standard all the time. And so I don't think we can necessarily worry about that right now. We need to be figuring out what are the elements that are going to be important. Short term, and Tina will go through this in a second, we've got 1 week for you all individually or for CIDM collectively representing many of you to provide some technical suggestions back to AHRQ through the NQF process that will then take us through the starting point for this longer journey. So this is a great, we're in the warm-up phase right now with this 0.1 version, I think it was designated, to get to the 1.0 version. Next slide. And I think we just have to understand that these safety events have many different stakeholders, many different perspectives. And what I worry about, and I think someone alluded to it, is that a single patient with a single multi-year effort, whether it be Crohn's disease or rheumatoid arthritis or some cancer or something, these can go on for years. And if we just look at each individual diagnostic encounter with a missed opportunity by itself, we may miss the holistic safety event that's going on. That doesn't mean we should be intimidated by trying to capture this long ongoing journey and not do anything until then. So I personally like the notion of what happened at this encounter that had a missed opportunity. But I think we also need to look collectively at the whole thing. And frankly, again, with the patient being the only person that is, one, highly, highly, highly motivated to get the best outcomes, but two, they are present at every stage of a long journey. We need to figure out their role in this whole thing. And we've talked about we need to extend this beyond the PSO environment, which may mean adaptations. We need to think about roles like I was happy to see emergency transport as one of the choices. I think Brad Kaufman may have had to leave. He's one of our coalition members from the National Association of EMS Physicians. But I think what I've understood is 30% of their calls never involve transport. The only diagnosis that occurs is from the EMS person on site, and then the patient is left behind. Does the EMS group use this kind of patient safety event reporting? And how about the communications that occurs? They have their own electronic medical record that doesn't speak to the hospital's electronic medical record. So there's so much more complexity here, and yet, per Hardeep, we don't want to make it any more complex than it is. So we have to find that balancing between the ideal and the practical and the starting points, the steps. So with that bigger picture, let me turn it over to Tina to bring us home. And if anyone has any questions or comments for me, either you can raise your hand or just jump in right now. Otherwise, we'll just move it over to Tina. Okay, Tina.
Thanks, Paul. So I'm just going to walk you guys through our next steps. So we want you to submit comments, as we said. So we have a couple options here. Option one is you can go in and submit your own comments. So you go to the NQF website, which is listed here. And Jerry, you can go to the next slide. Thank you. And it'll ask you to either create an NQF account or sign in if you already have one. And then it'll prompt you to enter the comments in each section. We actually have a video tutorial that Jerry put together that's going to walk you through exactly how you submit those comments. So after this meeting, we're going to send out the recording of this call, the slides from today, and then also this short video tutorial that's really going to walk you through how you submit them. There isn't a formal option to submit a letter, so it is really this drop down and into the boxes your comments. So if you do submit comments this way, please let us know and send us a copy of your comments. We really want to make sure that we're collecting everything from the field and have an idea of what our coalition members find important and areas that they see improvement potential. We're also going to, in this follow-up email that we send you, offer some office hours. So Jerry's going to offer a couple hours this week and then an hour on Monday, which is just an open Zoom room, and you can feel free to come and ask any questions if you're trying to either formulate your comments and have questions about how to do that or how to submit them yourself. We're here to help. Next slide. The second option is we've heard from several groups that they are really interested in participating and want to submit some sort of comment, but that this isn't really in their wheelhouse and actually going through the nitty-gritty and submitting the technical comments. So we do want to offer an option. We, CITM, are putting together a letter that we're going to submit with our technical comments. And we welcome all coalition organizations and everyone on this call to sign on to that letter. So the way that that's going to work is we're going to send the letter around to everyone in the coalition. Our target date is this Friday, and we'll have a simple sign-on form that'll go along with it where you can just put your name, organization name, and that you agree to sign on to these comments. There's also going to be a free-form text box on that form that you can add any substantive comments that you have. We're going to attach those as an appendix to our letter. So in order to meet the deadline of actually submitting the comments, we will ask that you complete the sign-on by the 29th. So as I said, we're going to try to get it out to everyone on Friday, and then you'll have the weekend and a couple of days next week before we need to have official sign-off. Next slide. So what's next? So first, submit your comments. As I said in the last couple of slides, we really encourage you to submit comments either through MQF on your own or sign on to our letter. More information will be coming to all of you if you want to take a look at the tutorial and see if you want to take it on yourself or take the time to read our letter first and see. Either option is absolutely a great one. And then what can you do? So as Paul and Jerry both mentioned, we really want people to identify some case studies and really test them against the current common format. So we've heard that a couple people and organizations have started to try to do that. We encourage you to continue even after the comment period ends. Really take some real world case studies and try to run them through this and see, does this work? Are there gaps? Where can we move this to the ideal state? And then we also encourage all of the groups to discuss this concept and this journey and what is currently happening in the field with all of your stakeholders. Gather information on what their needs are, what their fears are. We would love to capture all of that and learn as we go. And then what will CITM do? So we're committed to keeping this conversation going. We've already had a couple full coalition meetings. We intend to continue the conversation with all of our coalition members, whether it's through larger meetings, smaller sub meetings, or if you just want to reach out to us and say, I've been thinking about this a little bit more, or I've talked to some of my colleagues and really want to talk to you about this further, we're always happy to have that conversation. And as I said, we really want to collect the wisdom of the field. You know, all of you are the people that are so passionate about this issue and that live it and breathe it every day. We want to make sure that we're capturing everything that you've experienced already, or any pitfalls that you find, or areas that you find really, really good that we want to identify as well. And then eventually we also are hoping to leverage the coalition to develop a white paper that defines the ideal state and the path to get there. Are there any questions before we wrap up, or final thoughts? Jerry, you can go to the next slide. So this one just has our contact information. So this is my email address as well as Jerry's. I'll send this out in the email as well, but please feel free to always reach out to us. And we have a couple minutes left if anyone has any last lingering questions.
Yeah, I just thought we might even, as Jeff, any nice comment, Jeff, thank you. But if you want to say anything as the ultimate beneficiary of this effort, certainly would be glad to give you the floor for a last minute or two.
You know, Paul and Jerry, Tina, all of you, it was such a great session. I think I can keep my comments very brief and just, reiterate the thanks. I'll emphasize one point you made, Paul, that while we certainly have thought long and hard and continue to think hard about scalability, feasibility, practicality, I think you really captured the point well. At this stage, we're trying to get a sense of the totality of data that would be the ideal for collection. And even though we sort of present the format in a reporting format, and that's usually the way that it's most easily digestible, we don't envision that form being used right in front of people. This is just a way to sort of, capture this sort of total package of data that we think is relevant, that the field in fact thinks is relevant for diagnostic safety. And then actually designing and implementing reporting systems is a later stage, and sort of thinking about where all that data comes from. We certainly do think about that. We don't hold off that consideration until the end step, but we like to start just as you described. So great session. Again, I'll stop there, but really appreciate you all getting the word out, and also thank you for the feedback. This only works as a standard if you know, folks contribute to it, and ultimately we all develop a usable form for kind of advancing this problem. So anyway, thank you again. I'll stop there.
And let me just also reinforce, Jeff, that this is a voluntary system. And so part of CITM's goal is to facilitate and catalyze greater adoption and utilization of whatever results to start to build that national learning network and all that shared learning. And so I think it's important that we continue to work towards getting to a more perfect nation, or rather a more perfect system. And then we drive utilization. So many organizations do not use the common formats, and we need to develop something that works for everyone, so they choose to use the common format. Great. Any other last comments or questions from anyone? Okay, well, we're going to give you a few minutes back into your schedule. Tina, thanks so much for coordinating and facilitating. Jerry, thank you so much for all the advanced work you did. And you'll see the follow-up communication from Tina that she described. Thank you all. We're adjourned. Bye-bye.
Thank you.
Thanks, everybody.